Dear audience, I'm here to present my PhD thesis titled Multimodal Treatment Strategies in Resectable Pancreatic Cancer. Starting with a quick summary. So 5 years survival patients with pancreatic cancer is unacceptably low, only 12%. The survival benefit of neoadjuvant therapy in resectable cases is still debated. Our systematic review and meta-analysis found no evidence supporting the superiority of neoadjuvant therapy in resectable pancreatic cancer. Moreover, we found better survival rates in upfront surgery arm. Besides clinical efforts, drug development and translational research are crucially needed, and to achieve this, funding and dedicated research capacity is essential to improve the outcomes in this challenging disease. So my name is Tamás Tölgyes. I work as a surgeon at Uzsuki Teaching Hospital, and our vision is to provide the most effective treatment to patients with pancreatic cancer, and our mission is to investigate the different therapeutic modalities in resectable pancreatic cancer. We have 2 ongoing projects, both focusing on resectable pancreatic cancer. The first one, titled Comparing the Effectiveness of Neoadjuvant Chemotherapy to Upfront Surgery in Resectable Pancreatic Cancer. This is a systematic review and meta-analysis. Some dismal statistics. So pancreatic cancer is the 11th most common cancer type and the 4th leading cause of cancer-related deaths, but it is expected to be the 3rd one soon. At the time of the diagnosis, less than 20% of the patients are eligible for curative resection. But what is resectable pancreatic cancer? To simplify that, when there is no distant metastasis and there is no vascular involvement, there is a minor exception when the vein infiltration is less than 180 degrees. So currently the standard of care is upfront surgery followed by adjuvant chemotherapy, but many patients do not receive adjuvant chemotherapy due to post-therapeutic conditions. This fact played a key role in the idea of neoadjuvant setting followed by surgery, and maybe in this way we can improve the survival rates. So our aim is to investigating the effectiveness of neoadjuvant chemotherapy in resectable pancreatic cancer. The clinical question is, does neoadjuvant therapy decrease the rate of mortality compared to upfront surgery? So we use the PICO framework. The population is patients with resectable pancreatic cancer. The intervention is neoadjuvant therapy, the comparator is upfront surgery, and the primary outcomes are overall disease survival, and the secondary outcomes are pathologic and surgical results. And our hypothesis is neoadjuvant therapy is superior to primary surgery in resectable pancreatic cancer. We conducted a systematic research last November in 3 major databases, found more than 15,000 hits, and included 15 articles, only RCTs. So let's review the results. The first one is a resection rate. It is a clinically relevant indicator because surgical removal of the tumor is the only curative intention. And we analyzed 8 articles, more than 600 patients' data, with a moderate heterogeneity attributed to different chemotherapy regimens used. And the pooled relative risk was 0.86, meaning patients with resectable pancreatic cancer receiving neoadjuvant therapy have a 40% lower chance undergoing resection. This result is clinically absolutely relevant and mathematically significant. The second one is the R0 resection. R0 resection has a greater impact on survival. So we analyzed 7 articles, more than 500 patient data with a moderate heterogeneity. And the pooled relative risk is the opposite because it is 1.22, meaning the probability of achieving an R0 resection is 22% higher with neoadjuvant therapy. And this result is clinically relevant and mathematically significant. Let's jump to the survival. The first figure, you can see 2 Kaplan-Meier curves using restrictive mean survival time analysis. And these two curves are closely overlapping, so there is no significant difference between the two arms. But if you continue with overall survival in the same ITT population with the same method, the difference is not significant again, but there is a mild superiority trend which supporting the benefit with survival benefit in upfront surgery arm. And finally, the subgroup analysis based on the currently recommended chemotherapy regimens, it is FOLFIRINOX and gemcitabine combined with paclitaxel. The difference is not significant again, but there is mild survival benefit in the upfront surgery arm. Our analysis has some strengths and limitations. We use the robust methodology to provide the highest level of evidence. We analyze the large sample size and analyze only RCTs. But there are some limitations to consider. The different type of neoadjuvant and adjuvant treatments elevate the heterogeneity. We include some limited number of borderline patients and non-comparative RCTs. So the conclusions are the resection rate is higher in upfront surgery, but the opposite in the R0 resection rate, it is higher in the neoadjuvant therapy. But currently our findings support there is no evidence in the survival benefit of neoadjuvant therapy. So in resectable cases, resectable pancreatic cancer, the first choice is upfront surgery, but patients with high-risk factors, neoadjuvant therapy can be considered. And for research, so we have to find factors to identify patients who benefit the most from different therapeutic strategies. So currently, we are working on grade assessment and manuscript writing. The second project titled Investigating the Effect of Prognostic Factors on Overall Survival Following Surgery in Pancreatic Cancer. So the background is close to the same. So I created a database in 2013 and recorded and followed all patients operated at our department. Currently, I have more than 400 patient data. And our aim is to investigate the prognostic factors on survival following pancreatic surgery. So the clinical question is, do the prognostic factors have a significant association with survival? We use the PFO framework. The population is patients underwent resection. The factors are surgical and histologic factors, and the outcomes are overall and disease-free survival. And our hypothesis is these factors has no effect on survival rates. And in summary, we have two ongoing projects. Regarding the first one, the planned submission date is this November, and regarding the second one is next summer. I would like to finish my presentation with the words from Mark Twain: the secret is to getting ahead is getting started. Thank you for your kind attention.
Can you go back to your main figure, the most important one?
The main?
Results-wise, yeah.
Choose one?
Yeah, yeah.
I choose this one.
So the outlook is bleak, isn't it? It's quite sad. So regardless what you do, 3/4 of your patients will be dead within 5 years.
Or you can see the opposite, because in
Yeah.
last decades or 2 decades before, there was the Kaplan-Meier curves, I think, was absolutely different. So we have a benefit comparing to these results.
What do you think pancreatic cancer treatment will be in 20 years' time, in your time,
Okay.
while you are a surgeon? What are you going to do in 2045 for pancreatic cancer patients? Because this is all about that.
Yeah. Thank you for your question. So I think currently the problem we are thinking about guidelines and to try to make the patients homogeneous. But in real life and real practice, I think the patients and the tumors are not homogeneous. There is a huge heterogeneity. And I think in the future, the individualized therapy will be the future, but we have to find the factors to choose the best treatment strategy. So I think that is the future.
And we need to find an effective treatment.
Sure.
That's the other thing. Maybe we will not operate on pancreatic cancer in 2045 because there's going to be a drug which blows it away. A very, very nice presentation.